The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with another edition of The Genuine Article. And I'm in Rome and talking to Dr. Luciano Agati. And Dr. Agati is professor of cardiology at La Sapienza University of the University of Rome. And he's publishing a fascinating paper in JACC that deals with the importance of being very, very quick to open occluded arteries in the setting of acute myocardial infarction. So, Luciano, tell us, why did you choose to study this?
Yeah, we decided to study this group of patients using magnetic resonance, and we perform the T1 and T2 wave sequences to be able to study together the infarct size, microvascular obstruction, and the area at risk. And magnetic resonance is a magnificent tool because it's the unique able to study the area at risk.
It was very clever, we thought, that you used the T2 weighted images for area at risk and then late gadolinium enhancement for an infarct size. And in that way, you could look at the variables in PCI that could reduce infarct size the most.
Exactly. In particular, subtracting the infarct size from the area at risk is possible to quantify the myocardial salvage. It's very difficult to, in humans, to quantify the myocardial salvage. That's why magnetic resonance is a particular technique. In this case, we divide our patients in 4 quartiles according to the time from symptom onset to the PCI, to balloon inflation. And we have very important results because we observed that the infarct size and the microvascular obstruction increase over time. But the most particular finding of our study was that the myocardial salvage is important in the first 90 minutes, but after 90 minutes is dramatically reduced and becoming like zero after 360 minutes. That means we have a very short time to be able to salvage myocardium.
And I think even shorter than we've thought in the past. We've had this imperative to open the vessel in 90 minutes, but what you're telling us now is that 90 minutes, even from the onset of symptoms, may be the outer limit.
Exactly. That's the new finding of this study. That if we consider that there is a time between symptom onset and arriving in the hospital, that the mean time in Europe and the US is about 90 minutes, and the time from symptom onset from hospital arriving to the PCI is about 120 minutes. That means that at the end, the total ischemic time is more than 200 minutes. That is very long because we really demonstrated that we lose a lot of cell after this time.
So the problem, it seems to me, is that mortality from infarction is going down very low. So I guess the consequences of the larger infarct size would manifest itself in heart failure remodeling.
Exactly. That's the main time. We were able to reduce the in-hospital mortality, but at the end, looking at the follow-up, there is an increase of heart failure people. That's perhaps the main reason is that we have a lot of microvascular damage because we are not able to treat on time these patients. If you look at the recent Cadillac study, we have the very important data because they demonstrated the database that at the end, people that were really well perfused on the microvascular point of view are no more than 35% of patients. That's terrible, this finding.
Sure. So should we consider fibrinolytic therapy if that can be given almost immediately?
Yeah, exactly. I think that should be one important idea for the future. That there is some increasing data on pre-hospital fibrinolysis, and they demonstrated that if you are able to treat the patients very, very quick, we may really reduce the mortality even as compared to patients treated with PCI. Thus, if we were able to treat this patient before they arrive in the hospital, perhaps we may really reduce the mortality also on late follow-up.
Well, we really like the innovative application of magnetic resonance to this problem, and you certainly have clearly defined the fact that even 90 minutes door to balloon may be a little bit on the long side, and we have to try to narrow that even further. For the Genuine article, I'm Tony DeMaria.